My name's Samantha Ng. I'm one of the transplant nephrologists at the PA. Meant to be chairing this session, but Handu wouldn't let me introduce him. So I've come to introduce Dr. Pramudith Sirimanna, who's one of our Pancreatic biliary surgeons at the PA. He's going to talk to us about liver transplant and the machine perfusion outcomes. Thanks very much for coming.
Thank you very much. Yeah, thank you very much for inviting me to talk about machine perfusion and liver transplantation. But before we get to why we're doing this, I think, like Marty and Doc, we've got to go back. The dashing chap on the left is Charles Lindbergh. He's an American aviator who conducted the first non-stop flight across the Atlantic from New York to Paris. And he had a sister-in-law who had a fatal heart condition. So then he thought, this is a bit crazy that we can't treat this, and teamed up with Alexis Carrel, the chap on the right, who's a surgeon, scientist, Nobel Prize winner. And they teamed up to create the first organ machine perfusion in 1937. And this work really paved the way for other machine perfusion, things like a heart and lung machine. So then fast forward to 1963, on the same year that JFK was assassinated, Thomas Starzl in Colorado performed the first liver transplant in the world. That was unfortunately unsuccessful, but he successfully went on to perform the world's first successful transplant in 1967. But he was also a pioneer in machine perfusion and liver transplantation and conducted a number of animal studies where he perfused these livers with oxygenated blood, both in cold and normothermic conditions. But the machine was clunky and inefficient, and it really didn't proceed to the clinical environment. And then in 1969, the advent of UW solution, which is a preservation solution that is used as a static cold storage technique, really revolutionized the way that we store these donors. And that's what we've been using and we still use today. So the principles of that is that when we do the donor surgery, we simultaneously perfuse the donor and exsanguinate the donor with this cold preservation solution using UW, and then when we take the organs out, we place it in a bag. We further perfuse it on the back table to make sure that all the blood's out, and then we put it into a bag with some more UW solution, and then place it in an ice esky, ready for transfer to the home hospital for transplantation. And the UW solution allows us to reduce the cellular metabolism with the hypothermia, and it has the components of it allows the maintenance of the cell membrane integrity. It also has adenosine, which helps with some of the metabolic demands in cold storage, and it has components that reduce reactive oxygen species. But understanding that these organs are still at significant risk of ischemic reperfusion injury and particularly vascular and biliary injury. So the problem in liver transplantation is that we have an increased demand for donors because we've expanded our indications. We've expanded the indications for transplantation in hepatocellular carcinoma. We're transplanting selected patients with intrahepatic and hilar cholangiocarcinomas. And as of last year, we have started transplanting highly selected patients with metastatic colorectal cancer. So this has put an increased demand on the need for donors. And when we look at the numbers, there's a bit of a paradox. We've got an increased number of donors, but we've got a reduction in the percentage that's used. And that's really a reflection of the aging comorbid population and particularly obesity and metabolic syndrome. And there's also a problem with DCD livers because, as you can see from the survival curves, the survival and outcomes from DCD transplantation is inferior to that of brain dead donation, and that's really as a result of the injury that occurs during the time of the warm ischemia during organ retrieval. So we've got to try and bridge this gap whilst increasing the pool of donors available. So like Oasis, organ perfusion has made a comeback. And there are a few devices available, and we've got the Organox Metra system, which was designed by Peter Friend in Oxford. This is the machine, and how it works is that we retrieve the organ as previously explained, and they still undergo the static cold storage with UW solution until they reach Princess Alexandra Hospital, and then we backtable the liver and dissect out all the blood vessels, and then cannulate the portal vein, the hepatic artery, and the inferior vena cava. We then attach it to a closed circuit where O-negative oxygenated blood is perfused through it. It goes through the oxygenator and it's actively pumped into the hepatic artery, about 20 to 30% of the blood. The rest of the blood goes into a reservoir, and it's passively infused into the liver by the portal vein. We also collect the bile, and we give nutrients, including TPN and vasodilators and other things via the system as well. We rely on our medical student perfusionists to do this, because they're up at night checking the blood gases and calling us, mainly Dr. Butler and Dr. Hodgkinson, about the results, and then titrate things according to those. This is really to assess viability. And the therapeutic effect, the reason why we do this, we want to reduce cold ischemia time. It allows us to assess the function of the liver, and it improves transplant logistics. We don't have to do these things in the middle of the night. We can do it at sociable hours when we're not so tired, which is great. In terms of the functional assessment, we can assess flow, we can assess acid-base balance, bile production, glucose, things that allow us to see whether or not this liver is going to actually work in the patient. And so initially we had some criteria that we would use, expanded criteria that we would use to put patients on this machine. And this was our initial criteria for DCD, which is donation after cardiac death retrievals. So we increased the age to 60. We made it so that any BMI considered, and steatosis less than 30% rather than minimal. And progression time was increased to 60%. So that's from withdrawal of life support to cessation of circulation, and then functional warm ischemia time of 30 minutes, which is the time from the systolic blood pressure of less than 50 to declaration of death. And then before we limited it to only short travels, but now we consider any hospital and any estimations of cold ischemia time. And the unit published their initial data. This was the first 20 organs, the first 10 of which were just were organs that were rejected, that were just tested on the machine using these viability criteria. So the demonstration of clearance of lactate, glucose metabolism, maintenance of physiological pH, good flows through the blood vessel, a soft texture of the parenchyma, and bile production. And then the subsequent 10 patients that were tested and assessed to be viable were then transplanted into actual recipients. And this allowed us to expand our criteria for selection of donors, and also develop stringent viability criteria to know that we're going to that these livers are going to work in people. So in terms of our experience, we've implanted 59 livers so far. So that's 59 livers that would not have been implanted if it weren't for this machine. 6 additional ones were deemed non-viable from testing. And you can see that over 2/3 were DCD livers. And when we look at some of the outcomes, importantly, that the median time that these livers were on the box were 12 hours, and there was no primary non-function. We've got an 18% early allograft dysfunction rate, which is actually compared to the literature on DCDs, which ranges between 25 to 45%. That's less. And our hepatic artery thrombosis rate is 5%, which is consistent with the rest of the literature. One of the main issues with DCD livers is the hit to the bile ducts and ischemic cholangiopathy. And our rates were 12.5%, which is actually good compared to or consistent compared to the rest of the literature. And for DCD without organ perfusion, it ranges between 20 to 30%. We've had to retransplant 3 patients, 2 of which were from ischemic cholangiopathy as a result of DCD donation, or on the DCD donation pathway, and 1 was for hepatic artery thrombosis, and we'll come back to that a bit later. So in terms of, you think, oh, these livers are on the machine for a while, and whilst they're in a sterile environment, what's the chance of mycobacterial contamination? And there is some evidence to suggest there is, and particularly with this lower study, which was done by our colleagues in Sydney, and they've got a machine that they've developed themselves that they put livers on for 7 days and test the function over a long-term period, and they found a reasonably high rate of a mycobacterial contamination. So it is something to consider. From our experience, all of our organs are perfused with cefazolin whilst on the machine, and blood cultures are taken prior to implantation. We had 3 positive cultures, 1 Enterobacter and 2 Candida species, and the organox times for those were lower than the median times. The Enterobacter was treated with 5 days of PICTAS prophylaxis from day 2. And then one of the Candida species was treated with 7 days of anidurofungin from day 2 as well, and there were no infective complications from these recipients. And looking at the literature, most of the data suggests that infection outcomes are either not changed or improved after organ perfusion as a result of the graft function being better, but also enables us to perfuse the livers with antimicrobial agents to get cultures beforehand and also reduce the ischemia reperfusion injury. Getting back to that ischemic cholangiopathy discussion, so it is a problem, and you know, a reasonable proportion of these patients may need retransplantation, and that adds to the burden of the wait lists and so forth, and it makes the surgery really difficult. So reducing that is a big priority for us. And like Yoda says, always hope there is. And of course, Yoda was, when he was talking about this, he was talking about hypothermic oxygenated perfusion, which has been shown to have a significant reduction in ischemic cholangiopathy. So this is where cold preservation solution is oxygenated and perfused through the graft. And this strategy has been shown to have excellent long-term outcomes. Comparing to normal thermic machine perfusion, It's a simpler setup. It requires less time on the machine, but and it's best suited for DCD grafts to try and prevent or reduce the risk of injury to the bile ducts. But it doesn't allow us to assess in real time the viability of the grafts. We've got to we think who are the best people to use this strategy for. In terms of ischemic biliopathy and DCD, you can see these rates. The static cold storage is about 15 to 30%. HOPE is about 6 to 10%, with normothermic perfusion being about 10 to 15%, and that's we're in that range. And on that, so our unit has recently gained funding in order to buy this another machine perfusion for the liver assist, thanks to Janske Reiling, who's the last transplant fellow, and she's currently in Birmingham doing some more fellowships. This has just landed last week. We all need to be trained on it, but the hope is that we will, for all DCDs, we'll have undergo HOPE for 3 hours or so prior to transplantation. And then for marginal grafts where we need to test the viability, they'll have HOPE with a plus minus combination of normothermic machine perfusion. And so this is all in hope of trying to improve the outcomes for our patients. Thank you very much.